Okay. Hi, I'm Meredith Kablick, and I'm the practice manager at Carolina Holistic Medicine. Welcome to the November 2025 issue of the Elevated Medicine podcast, available on Spotify and Rumble. Today, we are joining physical therapist Marissa Muccio, who is the owner of the Scoliosis Specialty Center. She will be discussing scoliosis detection, treatment, and other degenerative spinal issues. So, welcome, Marissa. We're happy to have you.
Hi, good morning, Meredith. Thanks for having us.
Yeah. So we're going to jump right in and talk about scoliosis itself. So can you talk to us about what scoliosis is for our listeners?
Sure. Scoliosis has been around as long as human health documentation has been occurring for thousands of years. But we've just recently, the last few decades, actually learned a lot more about it. It is not a regular spine that is out of alignment, but in fact, it is a complex, multi-system, three-dimensional condition. It does have genetic underlying factors involved. It's a disease where the structures of the spine don't grow evenly or symmetrically in their shape. And that change can occur at any aspect of that spine joint and those bones. So it has a three-dimensional component to it. And so sometimes I think when X-ray was invented, that kind of set us back a little bit. X-ray kind of is that flattening of that three-dimensional. And from there on, we began to think about scoliosis in terms of left and right and that S shape or a curve. So you'd have the concave or convex. But really, the reality was that it was biomechanically more like a spiral or a soft helix, three-dimensional shape. The disease itself is finished for the most part when your bones are done growing in that post-puberty stage. So I kind of say it's like a numbers game and a location game, right? How large is the curve when your condition is finished, when your bones are done growing, and where is that located? That gives us information about whether or not there's any risk to your overall health or quality of life as you're aging.
Okay. So when does it typically start? When do you start seeing the most early signs of it?
So, scoliosis itself um, describes the change in the spine, which can occur in other conditions. What you and I were just discussing was idiopathic scoliosis. You can have other causes for other changes in the spine, but the most common form of scoliosis is idiopathic, and it begins in that puberty time frame, so adolescence. There is another group that's called juvenile idiopathic scoliosis, and the criteria for that is if you were diagnosed under the age of 10. But generally, somewhere around before puberty or during, that's when we see that rapid growth of bone, and that's when we can see changes to the shapes of the structures of the spine.
So what are some of the causes of this? I know you mentioned genetics, but I mean, are there other factors as well?
Correct. It's still not really well known, and there are multiple avenues of research. Um, they do have an idea that there's over 200 different genes, but at the same time, it's not quite as simple as mom and dad have to have it, and then the kids have it. It can skip around. And so we know that there's a lot of individual factors as well. How does that person's genes turn on and off? Are there environmental aspects to it? So we're still under investigation as to the full understanding of the underlying cause of scoliosis. But what we do know is that it's not teenagers that are on their phones slouching in their beds too often. It is not heavy backpacks, although heavy backpacks are a reality. And as a good spine care, hopefully kids are learning to put them both straps on their backs and keep that weight higher and centered. So keeping those straps aligned, but it's not the cause of scoliosis.
Okay. So how do we perform screenings for this to be an early identifier of it?
Screenings have become so much more important these last 10 to 15 years. Now that we have solid research on treatments, it's become even more important in discovering the curves as early as possible. So prior to 1996, the United States had federal guidelines that recommended all kids receive scoliosis screenings in school. After 1996, unfortunately, at the time, because there really wasn't medical research for the early treatment other than surgery, they found it was just too fiscally burdensome and administratively challenging for schools for thousands of kids, and they lifted that requirement. So approximately half the states in the United States still have school screening and half don't. Either way, screening can be performed, should be performed by your skilled, trained healthcare providers. So either pediatricians, family doctors, nurses, certainly physical therapists that have been trained in scoliosis. But it's not just for the healthcare licensed professionals. We, for example, teach our parents how to perform screenings and the use of those tools so that they can help participate in monitoring maybe younger children in the family or monitoring their child that's actively under our care. So it isn't really simple and straightforward. Some of you might remember from school where you had to put your hands together and bend forward. That bending of the spine, we know because of the three-dimensional change in the structures, it causes the spine to rotate. And when you bend forward, when the spine turns, it carries the rib cage with it, and you'll see that prominence. So that's called the forward Adams bend test. And once they're in that position, the valid tool is called the scoliometer. Okay, and you see that little ball that moves? If you were to run this over the spine in that bend position, someone with scoliosis would pretty much stay around centered. But someone with scoliosis, you would start to see the rotation and you would see that ball move. This is called the scoliometer, and it provides the measurement called the angle of trunk rotation. And because it's described in terms of degrees, it can be easily confused with the X-ray measurement, which is also described in degrees, but it's a different measurement. So the X-ray or the Cobb angle is not the same as the angle of trunk rotation in the scoliometer. But generally around 5 degrees, we start to take a look at needing to get an X-ray. Because the reality is kids don't grow evenly anyway, and there can be small variations. So you certainly don't want to be sending kids with small issues for X-rays and having a higher chance of false positives, right? So somewhere around 5 degrees is typically what we look for. It can go as high as 7, especially if there's no family history. But family history for screening is kind of tough. We're really only a few generations away from grandma was just bent over and nobody knew it.
Right.
And smaller curves can go completely unknown. We still to this day in our practice have women pre-menopause, post-menopause, they're maybe having an episode of back pain and they get a set of x-rays and they're shocked to find that they had scoliosis all those years. They're like, oh, that's why my pants were never quite even. Or I had one shoulder that, always looked like it was down in family photos. So it's still not uncommon that the family history is not clear.
Right. And there typically, now clarify this, is there typically any pain involved or not really because it's just gradually happening over time?
So historically, in medical textbooks across disciplines, it was pretty much assumed that idiopathic scoliosis did not cause pain. Now with more research, we understand that approximately 2/3 of kids don't have pain, and that's great. And a lot of them are young athletes and very strong. And it's another reason it's easy to miss. Pain is not a predictor that says, oh, something's happening, go to your physician. But for the third of the kids that do have pain, we're beginning to understand a lot more about why, what makes that different for them versus the other portion of kids. So when we look for pain, we have a few more questions that need to be dug into when we're talking to our patients about that. Because growing pains is just a part of a lot of kids' growth. And so that's not to be confused with pain that has some type of connection to either the musculoskeletal or genetics or other systems within that particular individual patient. So again, another reason to have a skilled, knowledgeable provider to sit and spend the time and ask those sequence of questions and dig a little deeper into that. And unfortunately, that's not often the easiest thing to find in today's healthcare is the providers who have their structure in their practices to sit and spend 30 minutes in conversation. We do. I know your practice does as well. That's part of healthcare. And we ask our patients more details. It's our skilled knowledge that directs those questions so that we can have that more robust picture of how to help our patients' health.
Yeah. So tell me, so what are the treatment options? Like once you have an early identifier and you've recognized this early on, what's the next step just to kind of like halt progression?
Important. So the first thing we want to have is that x-ray. That x-ray, you need to have at least a 10-degree Cobb angle on that front-facing x-ray in order to even be diagnosed with scoliosis. And that, again, just harkens to not everybody grows 100% even, and small changes are perfectly within the realm of normal and not to be concerned with. But we do watch overgrowth. So the second thing is to identify how and where they are in their growth timeline. And it's not always about age. We can't clock it. Puberty can be very variable. One of the most modern changes for identifying growth has been the hand x-ray. We have a test called the Sanders modified score. We take a look at the joints in the fingers, and those stages can help us identify when a child is in that puberty peak growth and when they're almost done growing. When the condition is active, we have several treatment options. If it's extraordinarily small and there isn't a large family and they're out of peak velocity growth, observation is perfectly fine. We don't need to disturb children's normal development and family lifestyle with unnecessary medical follow-up. But keeping that observation close together during that growth is something that has changed. Historically, pediatricians were really kind of sort of mistakenly saying, come back next year. And what they didn't realize is they were bridging that peak velocity growth, and what was very small 10 months ago can very easily become a surgical candidate size curve in that quick of a time frame. So regular monitoring, whether it is clinical monitoring or regular scheduled x-ray follow-up. The great thing about the more recent invention of EOS low-dose radiation x-ray machine is that we can take x-rays now that are anywhere from 50 to 80% less radiation. So we don't have to sacrifice monitoring for protecting our growing kids from cumulative radiation exposure at the same way. So when we have access to that tool, we can monitor during that peak growth a little closer, maybe every 3 months or 4 months. And if they're slowing down, we'll check up in 6 months or 12 months. So after observation, if we start to see curves really moving forward and they're progressing, and they begin to hit somewhere around 15 to 20 degrees, we're starting earlier treatment now. The two forms of non-operative treatment that have a robust body of medical evidence is scoliosis-specific physical therapy, or better known as SCHROTH. That was the last name of the mother-daughter team in Germany that invented this method. They had scoliosis themselves. And it has gone global over this last century with at least 6 leading schools that teach healthcare professionals globally. The second non-operative treatment, which has very strong research behind it, the strongest type of research, is bracing. We now know that with higher dosage of a good three-dimensional controlled brace, you can have upwards of 90% success at halting the progression.
Oh,
Now, in social media and online, there's lots of conversation about correction. Can you get improvement? Can you reduce the curve? And historically, that was not the case. But now we're understanding something called growth modulation, where the external pressures and the exercises, for example, maybe even the internal pressures of the muscles as they're growing, if that's applied on a high enough level and dosage, we can start to see shifts and change in that asymmetrical growth. There's some literature and research that's emerging that's identifying growth modulation during good, high quality bracing. And we suspect there might be those underlying mechanics as well in some of the physical therapy application. But certainly the two together are some of the most powerful non-operative treatment. And then we step into surgical treatment. And that can be really scary for a lot of our families and patients. There's no doubt that the traditional fusion surgery, where people might remember, those rods that are placed, the rods are actually there to help hold the spine in a much more corrected alignment while the bones are fusing. The material that they put along the spine makes them fuse in a straighter, more three-dimensionally corrected position. Once that's healed, actually, the rods are not necessarily needed, but they certainly stay in there for the vast majority of people.
Okay.
The second type of surgery that is more recent, the last 15 years, is harnessing that concept of growth modulation, and it's called vertebral body tethering. And there's a small flexible cord that is also surgically applied. And as that cord applies the pressure during growth, it helps to modulate and change the shape of those structures. So that needs to be applied when there's still growth for that optimal change in reducing the curve. And vertebral body tethering is considered a minimal surgery compared to the major surgery that is the historical fusion. And they're still working out. It is only 15 or so years old, and it has not got a lot of long-term outcome research yet, obviously. We don't know what happens 50 years later, but we do know what happens 30, 40, 50 years in people that are fused. So understanding where your child is, or you as even an adult, where you are individually, again, becomes absolutely important that you have that individual factors taken into consideration, whether you're going to use exercise, bracing, or a type of surgery.
Okay. So let's go back to talk about some of the exercises. Now, the physical therapy, is it kind of similar to yoga, or is it different types of exercise? Like, what are kind of like the components of it?
That was very interesting. I happen to have been one of the first early physical therapists that was trained in the United States in this. Schroth-based scoliosis-specific physical therapy. First, it's not at all the same as general physical therapy. And that's because the training is extraordinarily specific to the condition of scoliosis. We evaluate the individual person's x-rays more than just the size of their curve. We measure their rotation. Generally, for a baseline, we also prefer to have a side x-ray as well. There are key measurements in the research that we follow along in that view as well. So once the comprehensive x-ray assessment is completed, we then evaluate that person's biomechanics. So when I teach kids about this, I always say, I can have two kids with the exact same curve. One kid plays soccer and the other kid plays violin, both 20 hours a week. They love their sports and their activities. Even though their curves look exactly the same, they have different brains and muscle systems. And that person who plays violin might have a lot of compensation above the curve in their head, neck, and shoulders, versus the child who plays soccer and is running and using their legs at such a high level. Maybe they're compensating for that change in biomechanics at the pelvis and the legs and the knees, and so to speak. So we really need to take a look at that individual person's biomechanics. And then we create what we call a curve specific exercise program for them, where we are teaching a full chain, three-dimensional, unwinding and elongating corrective movement pattern. So basically, it's like they're learning where to move their curves into better alignment. And then once they're in that corrective position, they're going to squeeze it and hold it. That squeeze, which in exercise we call an isometric, right? Where it's not moving, it's just squeezing and applying that pressure to those structures that are growing. We do know that type of exercise, isometric, grows and increases the volume and the size and the strength of those very tiny muscles that are surrounding the spine. They're called multifidi. And they're usually no bigger than like the tip of your pinky. And they go from one bone to the other in multiple directions. So it's a little bit more involved and curve and spine specific than just your general core, right? Which is a common misconception. The second thing is to think that people can just pull off curve specific exercises from online or books that they might read or regular spine exercises and think that that is necessarily applying to their curves. One, regular spine exercises that you might find in a typical orthopedic general PT are based on typical spine biomechanics. Remember, a spine with scoliosis does not move the same way. So we can't expect the same biomechanics. And it's not a surprise that the research shows that general orthopedic physical therapy in the history did nothing to stop the progression. And in the adults with symptoms or adult biomechanical collapsing, it doesn't help them either in the long term. So now we understand that we need to have curve specific exercises. Does it look a little bit like yoga and Pilates? It might share some parts to it, in that you're really slowing down a movement. You're taking a look at each individual block or section of your body and how it's moving. So there are definitely yoga and Pilates classes that teach people. But again, those are for general spines, and they're not the same as scoliosis specific skilled physical therapy. Now, people with scoliosis can do yoga and Pilates and regular exercises, and we highly encourage that. That's global strength and wellness. That's a wonderful thing. But if your goal is to treat something specific, either the active disease or symptoms, you need to have curve specific treatment.
Okay. And then tell me a little bit about the bracing. Like, I think when you think about spine scoliosis from the olden time, you think about those big metal like contraptions that kids had to wear, or braces on their legs like Forrest Gump. So what does it look like now in modern days? Because I feel like it's not as common to see it.
Well, a lot has changed in terms of bracing. The Milwaukee brace, which is what I think a lot of people, think about in terms of in the movies where the metal piece went all the way up under there. We've certainly moved beyond that. And that had some real detrimental effects on people's psychological health and wellness, and may not have been necessarily worth it at the time. But three-dimensional rigid plastic bracing is still kind of challenging sometimes. And we do know in the research that the longer you wear it during the day, so kids somewhere about 18 to 20 hours a day, the brace corrects them three-dimensionally and holds it in that correction while they're growing. There are some braces that are used only at nighttime. And those are called overcorrecting braces. And again, you have to have the right kind of curve, the right type of age, and a skilled orthotist who's making that brace, because it overcorrects and pushes to the other side, and you can't really function and walk around in it. And since a little bit more growing of the spine occurs during sleep, that can help in that growth modulation concept, where they're overcorrecting and hopefully helping to halt the progression. But when nighttime bracing overcorrecting is not successful, we move to rigid full-time bracing, 18 to 20 hours. And that does show, again, the upper end, almost 90% success at halting. Now,
Yeah.
most of those braces don't go obviously beyond the chest level, under the armpit, but they can cover some of the hips, whether that particular child needs help controlling their pelvis. So sometimes it can be challenging, but there's so many fantastic peer support groups out there with international reach. Higgy Bears is a fantastic nonprofit organization that helps little kids and teenagers, preteens, with stuffed bears that have braces themselves, and that psychosocial support where you don't feel alone. Because if you have a smaller class, it's possible you might be the only one, or maybe they're having to wear their brace at when they get home and you just didn't see it in school. Curvy Girls Scoliosis Foundation is another one of those fantastic, where the girls get together and they really help support each other. And there are chapters for both of those organizations across. And research shows that when they have that kind of support, their understanding and adherence to whatever treatment, whether it's bracing or exercise, goes up. So helping them and parents get education as well and support.
And they're not wearing these for forever, typically, right? It's just for a finite amount of time for their treatment.
Correct. Correct.
Yeah.
It could just be that year, or maybe a year and a half, where they're really in that puberty growth spurt, and it weans off a bit maybe as they get closer to being done growing.
Yeah.
Yeah.
And that is a hard time of any child, especially for young girls. Like that's the peak. You're aware of everything around you and how you're viewed. So I know that's a really difficult thing for parents to have to work on with their child, in addition to the physical improvements. So yeah.
It's been our experience over the last 15 years, when you put a good team together, and that includes psychosocial support, parent education and support and understanding, this ability to sit down and have conversations in healthcare, we really find that our kids rise to that occasion. They are stronger and better for it, and they can actually thrive. We have some teens that end up in the medical field simply because of their journey and experience in scoliosis, or they're turning around and really helping the younger ones come up and navigate. And it's just been a wonderful thing to watch that over the years.
Yeah, that's an amazing sense of community,
It
for
is.
something that's very specialized. So that's fantastic. Well, I want to pivot a little bit more from adolescents to adults, and talk about how scoliosis is identified in adults at a later age. And I know that, osteoporosis can sometimes go hand in hand with scoliosis. And I know that that's a big issue with, especially with older women, with not having enough, calcium and bone health and things like that. So what are your things that adults that should look out for if they're starting to feel like they're having issues with their spine? Like, how do you identify it as an adult versus when it's being monitored more as a child?
So that's a great question, because historically, and actually still a little bit now, when kids don't need surgery and they're done growing, it's often bye, have a nice life. And they are out of that pediatric healthcare box with very little instructions or directions about, other than, if you have any problems, go see an adult spine specialist. But unfortunately, not all adult spine orthopedic specialists understand scoliosis as much as, say, the more common things like a herniated disc or a musculoskeletal injury from adult work, and so forth, or sedentary and I've gotten weaker. So those are things that occur to a typical spine. And again, not the same thing as a spine with scoliosis that is aging, and being able to follow and understand the research that is specific to scoliosis. So we understand some factors like vertebral rotation are correlated to having more back pain. Things like location, where the curves are lower in the bottom of the rib cage and in the lumbar spine or thoracolumbar, those get used a lot, right? That's the location where most human biomechanics takes place. So just daily use and movement in that, we can see some biomechanical creeping, increasing some of those scoliosis measurements. But a very important distinction, and it's very important for older women to have this clarified, is there's a difference between a aging adolescent idiopathic scoliosis and a different scoliosis diagnosis that is called degenerative or de novo, means new, right? That is someone who had a very straight spine all of their teen years growing and in their young adult life. And as they aged, the degenerative process began in the lumbar spine, usually in a very focal location, usually one or two locations. And that change in the discs causes the spine and the trunk and the body to start to shift and deviate. And so it is called scoliosis because of that change in the shape, but it is not the same concept or disease or diagnosis as an aging adolescent idiopathic scoliosis. So first you want to understand which one you had, because that can be tough when you may have not known you had teen scoliosis until you're in your 40s. Which is it? So again, a very skilled physician to provide that initial diagnosis and difference, and understanding that the risks of prognosis and what is coming as the years progress are different also between those. We do know de novo is a faster, much more progressive condition of degeneration. Now, osteoporosis, surprisingly, is kind of higher risk within the teenage as well. There's research to suggest that kids with idiopathic scoliosis have slightly less bone density than their peers without scoliosis. So even as teenagers and young adults, their bone quality may not be as optimal as possible. So you can certainly imagine, as someone with scoliosis navigates life, variations in nutrition, exercise, weight training, experiences more sedentary lifestyles in the United States, we see more degeneration take place at those later ages. And of course, menopause. Speaking as someone already through that, it can really hit multiple systems and it can really change curves. People may not have even considered their curves all of those years. Now in menopause are finding more and more increased frequency of episodes of back pain and so forth. So having early detection, what are your baselines? If you're in your late 40s and early 50s, talk, and you have scoliosis, talk to your healthcare providers, put together a plan so you know what your baselines are. Maybe talk about DEXA scans, talk about ways to increase bone density and quality, whether it be nutritional supplement, pharmaceutical supplement, exercise and weight training. All of those might be options to discuss with your team. And then watching it. Let's put in place a monitoring plan. Knowing what your baseline spine measurements are with that front and side x-ray is critical. Because if you follow up in 2 years and you see changes, now we have to make a plan for addressing that adult biomechanical progression and see where that treatment option takes you. one of the biggest challenges is unfortunately in today's modern healthcare, um, if someone in their 50s just goes to a regular adult spine and they go to regular PT, and we know that doesn't have the durability, and nobody's really provided that comprehensive education about aging scoliosis, there can also be this kind of shared perception that you might want to push surgery off as long as you can. And it goes decades and decades of decreasing health, global strength, wellness, quality of life for something that is not going to be held back by just exercise or even adult bracing. And
Mhm.
unfortunately, if you wait too long for the surgery, your outcomes are likely to become less successful and more complicated. So again, that skilled conversation where you're making that patient shared decision-making process, where you're putting together the current research that helps patients to understand what their risks are, what their timelines are, that if you want to try non-operative and it's working, great, keep monitoring, right? If at some point it doesn't and it's not holding, then we switch to a preoperative plan of optimizing your health and wellness so that you can maximize the success of a good surgery. Because the research does show that for those that are failing in the non-operative, the surgery has better long-term health and quality. It's physics and geometry. Sometimes it just needs to be brought into more alignment because gravity kind of is not going to be kind over aging years.
Yeah, that's incredible. So what do you feel like are some things that adults need to be aware of, or what's the preventative measures that we should take in order to, prolong the health of our spine?
Absolutely. Number one thing, especially in today's sedentary life with more phones, more tech, more computer, maintaining a overall general health and activity is key. Now, that might be easy for our kids that are athletic, but it might be more challenging for our kids that are more academic, more tech, maybe more artistic, and thus more sedentary. So for those kids, creating small but easy habits is your best bet. Maybe it's a daily 15-minute walk as parents and the kids. Bring them out together, making sure that smaller, easier ways of creating healthy habits for spine health and activity can take place in your family, even for those kids that love that tech or academic or artistic pursuits that keep them more sedentary. Early screening, absolute number one thing you can do preventatively. And considering this is such a common orthopedic condition, it affects millions of people in the United States. If you hear about scoliosis, ask your grandparents, ask the older family members. I heard a podcast about scoliosis. Does anyone in the family that you remember, do they have scoliosis? Have that conversation, because I'm always surprised as a healthcare how many parents come in and say, "Oh, I had scoliosis, but it's a small one, and I never thought anything of it." And they missed the change. If you know it runs in the family, you screen more often for your children and grandchildren.
Yeah.
So that can be a huge help preventative, because we know when we catch it early and younger, we can really impact what it's going to be for that person for the rest of their lives. Because small curves don't matter as much. The
Hmm.
long-term research shows that curves that are under 30 degrees are kind of stable and don't necessarily have a lot of difference between people with small curves and people with straight spines. I say go hike Kilimanjaro. We've got Olympic athletes, um, professional athletes. We've got all professions out there that are living their best lives succeeding with the curves. So it doesn't have to be as scary as it might seem, especially for a lot of people that see that x-ray for the first time in their kids and it just hits them so hard.
Yeah, yeah, it can be. Yeah, you always worry about your kid in
Of
every
course.
phase of their life. So,
I think we
yeah,
worry about our kids more than ourselves sometimes.
absolutely, so true. Well, Marissa, tell our listeners where they can find you and where they can reach out to get screenings done for their kids.
Well, at scoliosisspecialtycenter.com, what we've done is created a opportunity for any family member or patients with scoliosis to choose what area of scoliosis they have questions about and click on for an educational consult. And that's a great place to have slightly more individualized conversation about what the current research is and begin to understand what scoliosis it means for your individual child or your family member or yourself. Pregnancy, menopause, pre-surgery, juvenile or adolescent. And so that website is a great place to get started for those educational consults, but also just keeping tabs on our social media. We, for scoliosisspecialtycenter.com on our Facebook and Instagram, we're constantly posting tips and pieces of research information. As a member of Scoliosis Research Society and SOSORT, the International Rehabilitative Medical Society, and the American Physical Therapy Association, our team is very research based. So we love sharing new research because it really is changing how we treat and handle these curves across the ages.
That's fantastic. Well, Marissa, thank you so much for for being on board with our podcast and sharing this information. It's automatically triggered a lot of things for me to think like, oh, okay, I need to go look at this with my kids' best. So, I'm very glad you were
Good.
able to share your time and your knowledge and expertise with us today.
Thank
So,
you for having us. We are really, really thrilled that you took the time to provide your audience with scoliosis education. It's pretty meaningful.
it is. It is. It's very important. Well, thank you all to our listeners for joining us today. This is the Elevated Medicine podcast, and you can find us on Spotify and Rumble. And we'll see you next time. Thanks again.
Have a
Thanks,
great day.
Marissa.